Heather Hirsch. We are thrilled to have you on. I have been counting down for this podcast, and I literally have just been perusing everything that you've ever written and your menopause course, the Thrive method. I mean, I've been just diving deep into all of it. And I have to say, I was just at a conference last weekend with Kelly Casperson, who's my favorite. And,
Yes.
Vonda Wright and everyone there, it was just amazing. But
Yes.
Kelly was like, she got asked a bunch of times. People are like, well, what about, a menopause course? And she was like, Heather, Heather, Heather.
So incredible.
So okay, I'm buying it right now and getting in there. So thank you for being on.
Oh, I am so excited. This is my favorite topic. And let's get into all the things.
Yes. Okay. So, all right, let's talk first of all about your menopause masterclass and why I mean, because it's available to any female. This isn't just like for trainers and coaches. And I love that because I feel like there's so much information that clients ask me, and I'm like, I don't know. I'm not quite yet. I mean, I'm definitely perimenopausal, but it was just a wealth of information. So tell us about how you came up with this course and what reclaiming menopause is.
Yes. Okay. I was just telling my last patient that I saw that I love teaching so much. And for so many years, especially when I worked at Harvard, I really felt like they really wanted me to become a researcher. And I tried and I tried and I tried, to fit in and to fit the mold. But I loved teaching. I was just such a natural at it. And I really, really loved it. And so I really started to lean into it. And so during the pandemic, I started YouTubing, podcasting, making TikToks. And that turned into just so many women from all across the country asking me all these questions that I just felt like every woman should know what their body is going through in the perimenopause to menopause transition. So from there, I came up with the concept of just making a course. I even went and took a really fancy course on how to make a course, which actually was really, really helpful. And so the Reclaiming Menopause Masterclass really was a way to get help with your own clinician. This was back when I worked at the Brigham and Women's Hospital in Boston, because I wanted all women to have access to this knowledge. And I knew that their clinicians also needed this knowledge. So then I went on to make a course for clinicians as well. And, I hope that I can, in some way, shape, or form, help women who maybe even never see me as their clinician per se, but get them to where they need to go with all that I've learned along the way.
Yes, I love it. So the Thrive method, let's break that down because again, all of these questions about when to take hormones, what hormones to take. I feel like everyone kind of gets into progesterone and estrogen, but then testosterone is kind of like, you know, the little sister that doesn't get invited to the party a lot of the times. When do we like
Yeah.
change those and when would we apply any and all of them?
Oh my goodness, yes. Well, so the Thrive method really was my way of thinking through like what I really do with my patients. So T stands for tracking, and that really helps us even know where to get started. Like we may know that there's these three sex hormones, estrogen, progesterone, testosterone, and they decline. So we're like, okay, we need to replace them. Well, in what order, in what route, in what formulation,
Mhm.
which one does what? And so you got to start with the basics, which is just tracking, because what symptom might bother Laura may not bother like her best friend. And so it could be that you're feeling hot and dry. It could feel like a brain fog. It could feel as though you're gaining weight or your libido is dropping, and tracking them based on if you still are in perimenopause, your cycles, and if you're menopause, if there are certain, times of day that things are worse or certain foods that trigger it. So it's tracking. The H stands for health history. So then what are you a good candidate for? Is there anything that's contraindicated for you? R stands for research. And this is where we dig into, like, specifically in my course, how safe hormone therapy is. And you got to remember, I made this course, I think in 2018 or 2019. And that is like 5 years ago at this point,
Mhm.
which seems like yesterday on one hand. And now there's a plethora of data really on the safety of hormone therapy, although it's still really confusing. So we really want to go through the research so that we feel confident, because my thing is that as a woman or as a patient myself, if I don't feel confident in my treatment, someone just says like, yeah, it's safe, or yeah, it's that's what you need, I don't feel like that's enough. So I want to make sure everyone really knows their research. And then I will stay on the I. This is investigating. And investigating is really where we say, okay, maybe your symptoms are more low progesterone. So let's trial progesterone. Let's investigate that. Maybe it's really low testosterone. You're very athletic. You've been athletic your entire life. You're used to a slightly higher testosterone. Maybe we investigate the testosterone. And then I kind of have this hormone stacking method because I like to do one thing at a time. I can tell you, I've seen so many women, they come to me on estrogen, progesterone, testosterone. They're still having cycles and they're like, I don't know what's doing what. And I'm like, totally fair and totally fine. We're going to start from scratch so that you know what each one's doing. So that gets us up to the THRI, where we really investigate. Because I think while I went on a little bit of a long winded answer, the question of like, how do I even know where to start or what hormone to start with? Really taking it back to tracking, what are you a good candidate for, feeling really confident about it, and then investigating like probably one hormone at a time based on your most problematic symptom.
Mm.
So I have a question about how do people know if they are in perimenopause? What tests do you recommend? If someone comes to you, I don't know, am I not? What do you do?
Yeah. Well, I'm laughing because I'm the answer is like you're gonna hate the answer. And so will listeners. It's like if you're asking, you're probably in perimenopause. And we have a joke like if you watch Saved by the Bell, you're probably in perimenopause. Like, you know, so yeah, there is no great test. And
Okay.
that's like the sticking point, because for diabetes, we know it's an A1C or elevated glucose level. For blood pressure, we know it's like greater than 140 over 90. Whereas perimenopause, there's no one number or test that rules it in or rules it out. I hear so commonly, my doctor said my labs were normal and I'm too
Mhm.
young, so everything must be fine. If you've heard that and you don't think it in yourself, you're probably in perimenopause. So the real answer is it's really a clinical diagnosis, which means the clinician actually makes the call based on your good tracking. If you've been
Mhm.
tracking irregular periods, if you're tracking symptoms of low estrogen, which is typically more hot and dry, hot flashes, night sweats, dry skin, low mood, and then low progesterone, which could be spotting in between periods, heavier periods, anxiety, insomnia. Those are the kind of things that a clinician is like, okay, this is perimenopause. There's just not enough of us. And
Mhm.
so
Yes.
many women, the frustration continues because they're like, I checked my lab. My doctor says it can't be that, and I know it's not the most satisfying answer. There are some labs that I do sometimes check, but we track them over time and then we put them in context. So there is no lab that's like, yes, you're in perimenopause.
Mhm.
It's more of a what is the context in which this is all happening over a persistent period of time.
Mm.
And being
Okay,
body
so
aware, like you said, tracking and knowing that you are having brain fog or you are having hair loss or different issues. Yeah. Okay.
Exactly. So tracking is like where I always take it back to. Like if there's one actionable item, it's really starting with just tracking, because that gives you so much knowledge. It also is a great starting point when you go to your own clinician to say, all right, the last 6 months, you pull it out and you're like, I've noticed hot flashes before my period. My periods are only lasting 2 days. My hair is falling out in droves. Literally, here's pieces of mine. Um, I'm having low libido and vaginal dryness. I've tried this, 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 and this. And then the doctor's like, okay, I can't gaslight you. There's nothing else I can say. You've got all the information right at your fingertips.
Yeah.
yeah. Okay, so if we start on if we're in perimenopause, which I think Well, Laura and myself both are because 'cause we're the same
Yeah.
age.
And we watch Saved by the Bell,
Saved
so
by the Bell.
We're
We know
good.
who Tiffany Amber Thiessen is, yes.
Yes.
Yes, we do. So if like, do you ever start women on hormones before they're completely menopausal?
Oh, every single day. Every single day. Every single day. Every single day. And this is such a myth. I'd love to dig into this, like, in terms of what you hear. But hormone therapy is something that can be used in perimenopause and is often extraordinarily effective. So when I was talking about that Thrive method, the I where we kind of got stuck, I think there's a V and an E, which stands for victory, and then E is basically just use hormone therapy longer term. But if we stay at that I, a lot of women, what I do with them as their clinician is help them investigate if they're in perimenopause, the use of postmenopausal hormones in perimenopause to see how that really changes or alleviates their big symptoms. So I do it every day. And this myth that you have to be 1 year of no periods before you can start hormone therapy is something that's very pervasive. I actually don't know where it came from. And this is probably based on my training because I like never went to med school saying I was going to be a menopause doctor. I did a 2-year fellowship training in midlife and menopause in 2014 at the Cleveland Clinic, and so I always just learned to prescribe HRT in perimenopause. So as more women were speaking out on social media, I learned that this myth is out there that they hear we can't do hormone therapy until you're in menopause.
Mm. Well, we gotta get rid of that
Totally.
rumor, I guess. So when do we add in? Because again, testosterone, what percentage would you say of women need testosterone or that you prescribe? Because it's not as everyone kind of does if they're doing hormones, they get the estrogen, progesterone, but why isn't testosterone? I know it's harder to get, and that's its whole separate issue. But what percentage would you say?
So this is a fantastic question. And as Dr. Casperson coins in a class that she's now teaching, is that we kind of call testosterone a data-free zone where like, gosh, like how many women need it? I don't know the answer, but I'll start with in my practice. So I founded the Heather Hirsch MD Collaborative, which is a telemedicine practice in almost all 50 states. I have amazing clinicians that work with me. Yeah,
So amazing.
they're just amazing, and because I couldn't see everyone, and it's just been wonderful to expand. So there's so many amazing clinicians available in again almost every state. We're missing like 3, and we're trying to get there. Um, but about a third, maybe I would say on any given day, about a third of my patients are on testosterone. So it's not everybody, but it's certainly not so few and far between that I'm counting them on my fingers. A lot of women will trial testosterone and see if they get benefits. Some women find that they're great when we just start estrogen and progesterone. They're like, hey, Heather, I feel perfect. I don't want to add anything else. I don't need anything else. A lot of women will find their testosterone's low and they may have the most common or the most well studied indication, which is low desire. But they may also find that it gives them some other benefits like energy or cognition. We don't know. We think that it might also help bone. So there's a lot we don't know in this data free zone. So I think the majority of women, if anything, could trial testosterone to see if it helps. Not all women stay on it for the long term, but I would say at any given time, about a third of my patients are on it, which gives you a good sense of like how many women really do feel the benefits of testosterone. It's a conversation totally ripe for just a lot more discussion because of course if we hear testosterone we think isn't that a guy thing, isn't that a male thing? No, absolutely not. Women make testosterone, and it's really an important hormone. Do we have data on what exactly it does in the female body? Of course not. Why would we have that, right? But as we are using it in clinical practice, a lot of us who are clinicians, not the researchers, I tried that. Nope, I'm a teacher and a clinician first. We see our patients often get a lot of benefit. And, again, as the clinician, we want to make sure your levels are still safe. We're not putting you any long-term risks. You're not going to lose your hair or grow a mustache, etc. I should end this by saying there's a small percent of women where testosterone can actually go up. And this is because it can be a stress response. The body is like, where's the estrogen? Where's the estrogen? Where's the estrogen? And the adrenal glands will start making cortisol and sometimes testosterone. So if you ever, are like, why am I getting a chin hairs or a mustache? Like, what is this? It could actually be a stress response, and you could actually be making testosterone. And so there are some women where actually we want to lower your testosterone.
Mm.
And I read and listened to one of your podcasts on testosterone, and I feel like it's great advice that people don't advise. Usually, doctors don't advise using the pellet because it's hard to um, dose it correctly. So, do
Right.
you usually just prescribe the cream, and do you ever do an injection for someone who doesn't want to do a cream? Like they give it
Mhm.
themselves a shot once a week or something?
Yes, I actually do both. The majority of my patients do use what we do, and actually what the Menopause Society recommends, and what there was in 2019 a a position statement from both the Menopause Society, the Endocrine Society, on testosterone use in women, and the recommendation was transdermal as first line. That way, it's really easy to control those levels, because if you're putting a cream on every day, my patient, her levels were just kind of creeping up, and she was like, I'm getting some pimples, Dr. Hirsch. I said, all right, go to every other day. That's easy to then drop those
Mhm.
levels.
Mhm.
With pellets, which last for about 3 months, and they're very, very popular. And I understand why they're popular. One, you feel amazing, but like, if it's too good to be true, there's probably a reason. And for a lot of women, you cannot adjust it, which is like, as a hormone doctor, that's like my worst fear, is someone calling me and saying, Heather, I'm having all this breast tenderness, or my hair is falling out, or I'm getting pimples, and not being able, just saying like, well, give it a few months, like they're gonna reach through the phone, and so that's really the problem, is they're
Mhm.
so hard to adjust, and some women metabolize them slow, some women metabolize them fast. So you could put a very long lasting medication, like a 3-month injection. You don't know what you are literally experimenting with your body. It's crazy. Now, this is different. There are actually weekly injections of testosterone that can be done. And again, these are all what men use. So men have more solutions available to them than we do. We just dilute them. So even with I do have a handful of patients on the injections. They just found that the cream didn't do anything. Either they would pour absorbers through the skin and they didn't get any benefit. So then we'll go to the injection. Usually we're doing one a week, because again, the longer you go, the more variation and loss of control you have over the dose. So you don't want to go like, let's do a high dose and make it last a month. That would give me anxiety. So we usually do a low injection, about the 10th or an eighth of a male dose every week. And that's another way that could be done.
Okay.
That's great.
Well, what
If
about
we move on to, like,
yeah,
vaginal topical estrogen,
yeah.
Yeah.
how many women? Because I feel like it's a no-brainer, like, just go ahead and use it,
Yeah.
as Kelly Kasperson says, it's skincare for skincare for down there.
Yep.
So, do you feel like you're always recommending that
Oh,
in
yes.
relation
Mhm.
with any of the systemic hormone doses?
Let's talk about this. It's 40% of women who are on systemic or whole body estrogens. What systemic means, also really need local vaginal estrogen, because that tissue, whether it's external tissue like labia, clitoris, etc., those are like external tissue, like it's just not going to absorb it, and it has the highest density in those receptors, so it just needs TLC. So 40%, or even, which is pretty much close to half of the women that take systemic, which is, recent reports say 2, 3, 5% of women take systemic hormone therapy. So that's not even high to begin with, but 50% of them also are on local vaginal estrogen. And I hear so many myths about this. I hear patients say, well, my doctor wouldn't prescribe me vaginal estrogen because I'm already on systemic. And I'm like, what? Of course you can use it. And of course you probably need it. I also hear like a complete other myth that vaginal estrogen will help, hot flashes and night sweats, of which it won't because it doesn't get absorbed systemically. So, because it doesn't get absorbed systemically, that's why you can absolutely use both. They're not like adding to each other. And it's just, so helpful. I absolutely wish it was over the counter. It is so safe, despite the fact that the FDA still slaps a black box warning on
Mm.
it that it doesn't apply to that medication. It came from the results of the Women's Health Initiative on oral Premarin and Prempro, which is nothing to do with using local vaginal estrase cream. So it's no wonder that like we're podcasting about this for now and years to come because it's like nonsensical. Like, I'm like, vaginal estrogen is so safe. Most women need it, even when they're on systemic hormone therapy. It should be over the counter. You should get a tube of it when you go home if after you've had a baby. You could use it after you've had or before your period when your estrogen drops, or definitely in perimenopause and for every day until kingdom come once we're in menopause. Yet it's still so confusing. It angers me
Ah,
just like getting all that out.
So
it
everyone
does.
should be on vaginal estrogen.
I think so. I guess the better question is like, who shouldn't?
Yeah.
You know, I mean, it's great prevention. Even if we're thinking it's not just the vagina, it's the bladder and the urethra. So the American Urologic Association recommends it as first line for recurring urinary tract infections. I don't know how many urologists are prescribing vaginal estrogen. They're probably prescribing antibiotics. It really is great preventative, even if you do it once a week to keep the tissue healthy. So the only people
Hmm.
that shouldn't, I do have a couple people where creams and anything in the vagina just causes like recurrent itis, like yeast or BV, or just like something that irritates them more. If it irritates you more, then let's figure out something else. There's actually a couple of other options. Like there's an oral medication actually that's non-hormonal, but there's very few people who shouldn't use it. And even that's not harmful per se. It's more annoying.
So, all right. We have estrogen receptors on the face. Yes.
Yes.
Okay.
I know
So,
where
do
you're
we
going with
use,
this.
do we use the same one? Because I'm like, is there a difference between what you would put on your face versus what you put in the vagina?
So amazing question. I'm pretty known for telling my patients that's no secret that they can use vaginal estrogen on their face, of which many of them have and many of them do. And it's funny because if they don't, as soon as I do a post or a podcast, they all email me right away. Hey Heather, can you send me some vaginal? Maybe they're on the suppository, or maybe again they felt like they didn't need it. So let's set the record straight. There's no FDA indication for any current estrogen product, be it compounded or estrase cream for your face. However, if we extrapolate its safety, and if you're using a pea-sized amount, maybe every day or every other day to your face of vaginal estrogen, the data from dermatologists does show that it is likely to be safe. And again, I want to be really careful about my words. I'm not saying it's 100% proven. I am, saying each to their own. Have I used? Yes. Okay. So, right. I know it's like, I want to also make sure we talk about the science and the facts, but this is also a data free zone. We don't have enough data on this.
Mhm.
Now, there are telemedicine companies that also offer a compounded version. And that's also very similar. I hear, although I've not used it, that it feels a little bit smoother per se, or maybe just better consistency than the vaginal estrogen. So all of those are ways that you could, with your doctor, use shared decision making to talk about if you could
Mhm.
use estrogen for your face. Wink,
Okay.
wink.
I'm just still like,
Very safe.
what the hell? Might as well do it
I
anyways. I
know.
mean,
I'm with you.
I mean, if we talk
it
about
cannot hurt.
it, yeah. what's happening is as we lose estrogen, we're losing the quality of collagen, which keeps our face looking structured and young. Uh, we're losing the elasticity, which is giving us the appearance of wrinkles. And also we can see those like aging spots or dark spots, right? And we're losing that hydration, which is why fillers looks we like fillers because it looks we women look hydrated and etc. So therefore, that's all the things that estrogen does. So it's not so far off to think if you added the tiniest bit of topical estrogen to your face. Now, I've had someone ask me, hey, Dr. Hirsch, could I use Divigel on my face? Divigel is systemic estrogen, and I
Okay.
wouldn't recommend that on your face. One, it's meant for something different, so it's gonna potentially even go through your skin or be faster absorbed, and so I wouldn't recommend that you use like estrogen gel that is meant to be systemic hormone therapy to your face, but I've gotten that question as well.
Okay, so while we're on this topic here, will every female have GSM? Or does that just like do some women bypass that?
You're asking like my favorite question. So
It's the best.
I used to teach it when I taught residents, at Harvard. I would say research says that 50% of women will experience GSM, but 100% of women will have GSM. Because what genitourinary syndrome of menopause really is as we lose estrogen, which inevitably we do if we live long enough, the pH of the tissue goes from an acidic pH of 5 to a basic pH of around 6 or 7. And therein lies what really causes GSM is the change in the pH. At that different pH, the cells are just like not happy. They don't want to function. They don't want to work. It's like the winter. They're like, no, blood flow is not coming in. It's not replenishing the tissue. This is why women can notice, for example, like difference in orgasm. It's not so much that all of a sudden it's not as fun. It's just that you're not getting good blood flow. You're not getting all the pH of the tissue isn't where it's meant to function best. So it's not your fault and it's not your partner's fault. It's your freaking pH. And so when you add vaginal estrogen, that lowers the pH again, and boom. So moisturizers are great. I love a good moisturizer. That's going to help just keep the tissue a little bit more hydrated, but it won't reverse the pH from that basic pH where we don't want it back to the acidic pH where it's happiest. You really need estrogen. So I hope that answers the question. Not all women may experience pain with intercourse or dryness or urinary tract infections, but also I don't know in that research how many women are one being honest because you might not want to say
Yeah.
that.
Yeah.
I don't know how many women, right? How many women are actually like, I think if it was like, it's okay, it's not going anywhere. Like that number might be higher. I don't even know where that number came from. But if you ask me, in my opinion, 100% of women will have the changes that are from the pH, from the loss of estrogen that will correlate with genitourinary syndrome of menopause or GSM.
Oh, okay. So that answers it right there. But when we look at the dosing, and I like
Mhm.
how in your program that you talk about the plan A, plan B, plan C, potentially plan D, where we
Yes.
go in with like the first line of defense and talk about it, but then, how often would you go back to your physician to get checked or to see if it's like
Oh, you guys are like music to my ears. I love all of these questions because I've got like really good answers. I think, but because how often should you how much tweaking should you do is like maybe the
Mhm.
question. And I think if for me, I will tweak with my patients till kingdom come, like till they're like, Heather, I cannot take another change. Like this is great where I am. But I always say to give an easy answer, I hope that all of my patients, my goal is at least at minimum, you feel 70 to 80% better and it fits into your lifestyle and you're really confident about it. Because if any of those things are off, like you're always going to kind of wonder. So I see patients routinely for second opinions. Like, well, I felt like 40 to 50% better. And not that I'm not at all trying to talk down about other clinicians. I think the medical system is a mess. There's, not enough information on this. We don't teach doctors. Visits are way too short. Like, it's no one's fault. We'll blame the system. But I'm like, girl, if we're on hormone therapy, we should feel 80% better. Like, not just a little bit better. Like, let's optimize it. So, and either it's the dose is too low, or maybe they're
Mhm.
like, well, I kind of do forget to take it. And you're like, okay, great. And they're like, well, I didn't know there was a patch. And you're like, yeah. So, it has to fit into your lifestyle. And you want to feel really confident about it. And so those are the things where I feel like I like to see my patients every 2 to 3 months until we're really, really close to that. I
Mhm.
think all women deserve that. I know it's just, harder said than done, or easier said than done, because there's so much that goes into that little statement of, I want to spend so much time with you on your hormone therapy so that you feel so good. Already we're like, oh, that's the dream, but I feel like that's what women really need.
But this is why you really started your online practice then, because I feel like I mean, I'm in this space. I'm not obviously not a physician, but I'm
Yeah.
well connected. And I went to my OBGYN and it was like not helpful at all.
Mm-mm.
So, such a benefit to be able to like you said, it was in almost every state. So if it's in your state, then you can just call in and do this,
Yeah,
via telehealth.
telemedicine. Exactly. I love telemedicine for this because, of course, the pandemic really kicked this off. But even before, when I was recruited to Harvard, I was like, we should be doing telemedicine. And they were like, oh, I don't know. Oh, that seems so new. Well, then we all know what happened in 2020. And so we all got our wish. But so much of what we're doing is talking, it is mental health, it is changing old perceptions about hormone therapy. It's talking about weight, it's talking about life stressors, things that you do as well. If you're as we're training women, etc., we're thinking about them holistically, their whole life, their family. When do they wake up? When does when do the kids get up? When are the kids leaving the house? All of that's like really important, and so much talking that it was really ripe for telemedicine. And then you could feel more comfortable talking about these things wherever you want. I mean, we do visits in basements, closets, attics, cars, you name it.
Yeah. Well, and that is one of the first questions anyone asks once they're not feeling great. It's, who do I go to? Who do I go to get my hormones checked, or that's can advise me on hormone replacement therapy? So I love that you started this too.
It is
So
so much fun. Yeah.
I'm making an appointment like when I get off the
Same.
I can't believe I'm not there yet, but
Yeah.
I'm
Oh,
like,
I'm
I'm
so
ready.
excited.
I'm ready to do something. How do
Yeah.
you feel about adaptogens for women that potentially don't want to go on any kind of hormone therapy? How do adaptogens, obviously they're not the same thing, but do they
Mhm.
help solve some of the syndrome or the symptoms?
Oh, definitely. Absolutely. And I love that you asked me this. And I know it's probably getting towards the end of our episode, but just because thinking about, I think this is so important to say right here too, is that um, I talk about hormone therapy all the time because there's so many questions, but you are not doomed if you don't want to take hormone therapy or you can't take hormone therapy. And I think of adaptogens as a really important strategy in one of my three buckets. So if the third is hormone therapy, let's work backwards. The second is FDA approved medications that are non hormone therapy. And the first is lifestyle supplements, complementary, and alternative medications. And so, really, I want to make sure that because I think this is really, really crucial to say that there is not one right answer, and you are not doomed if we choose not to take hormone therapy. But adaptogens can be extremely helpful. A lot of my patients, and this also might be a lot of self-selection, because I tend to see patients who have tried a couple of things before they come to see me, and so it's amazing how much more knowledge women have at the start of their visit now versus 5 years ago versus like 8 years years ago when I was doing this. And so there's so many good supplements that can really help. And, I like to kind of go by symptoms when we think about, ashwagandha is fantastic. Rubiola, green tea extract. A lot of them can be really, really helpful, especially if there's like anxiety or there's insomnia. And then some of the more herbs are really great for hot flashes and dryness and etc. So absolutely everything has a role and everything is really important.
So what is the role of it for osteopenia or osteoporosis?
Yeah.
Hormone therapy has been shown to help with this, right?
Yes, hormone therapy is FDA approved to treat osteopenia, which is the precursor to osteoporosis. And I was just teaching yesterday when I said something. We often, I think, as women, or women are always, if they get diagnosed with osteopenia, they're told, "Oh, you've got a little bone loss. Take some vitamin D and calcium." That's all women should be taking, vitamin D and calcium. It's not necessarily adequate for osteopenia. And it's like we care so much about pre-diabetes, like, oh, we don't want you to become diabetic. We've got metformin and we got this and da 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 da. But so why don't we do the same thing when it's like pre-bone loss?
Mhm.
And I think if more, this is where I almost like the medical field is failing women, because it's not so much that women think like, well, why didn't he give me estrogen? They're not being told that estrogen is treatment for osteopenia and can prevent osteoporosis. So I went off on a tangent there because you can see I'm so passionate about like all of these questions. You guys are just like giving me the, the best questions, because these are real scenarios. It's not FDA approved for osteoporosis. So once you're there, it's not necessarily proven to help you get out of osteoporosis zone. But again, I diagnose so many women with osteopenia because we're delaying bone densities, or their doctors have told them just take some calcium and vitamin D. And I am just like, oh my gosh, why do we do this to women? We
Yeah.
downplay this, but we wouldn't downplay pre-hypertension or pre-diabetes, or if you had pre-cancer, look what we do to you for pre-cancer.
Mhm.
Why is it just that bones are like, oh, you sweet thing, you'll be fine? It's so patriarchal.
Well, then weightlifting really comes into play there, and strength training, which I think the message is getting across very
Yes.
strongly. Thank goodness
Yeah,
to social
finally.
media. But
Yeah.
that plays a huge role in turning that ship around.
Immense, immense. And I think that that message is so important of strength training. And, again, I think you're absolutely right. I have, agree. I mean, I just started strength training again and I feel like, oh gosh, it's so hard. Like you've been a cardio baby for so long. But it's I think that again, if you grew up and you know who Tiffany Amber Thiessen is and you watch Saved by the Bell, it is more likely that you know eat carbs, low fat, right, and cardio, right. That's what I was
Yep.
trying to say. And switching that mindset, I do think that it's getting around, and a lot of women know increase the protein, increase the fiber, add the weight bearing. So I think we're doing a really good job.
Yes. Well, Heather, as we wrap this up, what advice would you give to a female that maybe is somewhere in between maybe even postmenopause, that maybe hasn't been on board with hormone therapy, but now is like, okay, well, I want to give it a shot, or I want to have a conversation about it.
Yes. My advice is always this: one, never stop advocating, because, now we have a lot of telemedicine practices, and there's, lots of options if you don't feel comfortable with your clinician. And the other piece of advice I think that's really helpful for women, and I say this to my patients a lot, is like, hey, we don't have to go on hormone therapy. We can just trial it, like you trying on a pair of jeans, right? You try
Yeah.
them on before you buy them. I mean, listen, you can buy jeans before trying them on, but half the time that works, half the time it doesn't. But I think this pressure of like, we can try like glasses. Maybe glasses is better than jeans, right? Like put the prescription on and see what the world feels like. And then we can make a longer term decision. So you don't have to be all in or all out. Like you can
Mhm.
trial it for a few weeks and see if it is improving your quality of life, because that is what it's meant to be doing. And if you've got a good clinician, not only is it hopefully improving your quality of life, they're helping you make the right decision and they're increasing your confidence in its safety, which is usually where that sort of hesitancy comes from. Because for 2 decades, we didn't talk about it as kryptonite. So I think that's my piece of advice, is that you don't have to be all in or all out. You don't have to be for it or against it, but you definitely have got a great clinician. You can trial it, and then through that process, you will learn a lot about your body, whether you want to take it long term or you don't, what symptoms it helped, what symptoms it didn't. It's so helpful. So try it. You can trial it. You can do the short term subscription. You don't have to do it for life.
Yes, you're not committing for
Yeah.
forever. So I really like, I think it was in the investigate stage of Thrive, where you gave like a printout that you can take to your doctor, and
Yeah.
you have questions on there to actually ask your doctor, because some of
Yes.
it is like, I don't know what to say.
Mhm.
And if they're not really well trained in it, then it's easy to kind of just walk away being like, I'm not really sure what to do still, even though I just went to my physician. So I
Yeah.
love that you can print that out when you take the course and take that in. That's
Yeah.
huge.
Yeah.
Eliminates a lot of the
Exactly.
barriers there.
I really wanted to make it so that my dream when I did this again, which was, I started this before I even had my own clinic, so you could really only see me at the time if you lived in northeastern, Massachusetts, was that you could really be successful in having a conversation with even the most either biased or unknowledgeable clinician.
Mhm.
And I wanted to give you all the tools so that you could do that. Especially because, a lot of women love their clinician. This is just the one area they weren't trained. And they're like, it's kind of like your hairdresser. You're like, oh, if she could only do bangs. But if she could, it would be fantastic. She could do everything. I think that
Yeah.
there are still those people who love working with their clinician for everything but this. And my thought was that also, here's my secret. If along the way, like Laura, you're kind of on this journey and you walk through this with your doctor and your doctor learns something, you are now changing the lives of the next 1,000 people that he or she might see. And there's kind of this back thing that's happening, which is where you are kind of teaching your clinician along the way. And I do think that for a couple years, like 3, 4, 5 more years, just depends, that many, many women know more than their clinician. But this is actually crucially important to speak up in a nice way, because then those clinicians are like, I need more training, and they're going to
Mhm.
catch up then.
That's
Yes.
powerful. Good point.
Well, Heather, thank you so much for joining us. I really wish that we had more time today. Where can people find you? Where can women find you, and get their own appointment online through this telehealth if they need it?
Absolutely. So it's jointhecollaborative.com, just like it sounds, jointhecollaborative.com. You can also find me on Instagram. I'm at Heather Hirsch MD, and across all my socials at Heather Hirsch MD. And I also have a new website where all my courses live, which is the Heather Hirsch Academy. And that's heatherhirschacademy.com. And that's where all my courses are. I know everything's just really grown. And it's so exciting because, again, I'm sort of, oh gosh, I want to strike while the iron's hot. Women are really galvanized around this topic. And so I want to do everything I can to make women's lives better.
Yes. Well, you are. And thank you so
Definitely.
much again for your time today. I know that you're so busy, but we have just loved having a few minutes of your time and being able to introduce a lot of this to our listeners. So thank you so much for joining us.
Thank you
Thank
so
you.
much for having me. This was amazing. Thank you.
Thanks for listening.
If you enjoyed this episode, please consider giving us a 5-star review and sharing the Body Pod with your friends.
Until next time.